Okay, contracture. Loss of passive joint range of motion. As I was saying before, this idea around a peripheral change in length of tissue can profoundly affect your abilities to move. In this case, a young boy with a traumatic brain injury didn't have sufficient extensibility of his wrist and finger flexors, and while he could open his hand a little bit, it was always quite precarious because he couldn't make that aperture wide enough to be able to pick up the glass. And as we're saying, it's actually a loss of that joint range of motion, so people can no longer get to that last part of the range. In terms of incidence, there's an interesting paper by Kim Kwar in the Journal of Physiotherapy where she followed up 200 consecutive stroke survivors. Obviously, in this aged population, there's a number of people that were dropped out because of death and so on over that period of time that she followed them up. But she found that in this population, 52% of this population had a contracture at one or more joints. This included the elbow, the wrist, and the ankle. So a high 50%, that's a high incidence prevalence. The thing that she was really interested in, though, was what are the features of the people that do get contractures? Is there some commonality between them? So the researchers can now start to focus on those people rather than continue to do the research across the population. Because by the time she was doing her research, the research was showing fairly clearly that the stretching papers, the stretching research was not positive. So is it the severity of the stroke in the first place? Is it the initial muscle strength that the person can actually generate? Does it have something to do with the actual control of the joint, of flexion, extension of the elbow, for example, in terms of their motor function? And what you found was that even the severity, these three things factored together, they only explain between 1 and 17% of this incidence of contracture. Completely unexpected. She had hoped that one of these, or perhaps all of these together, which we can actually start to measure, would have given us some anticipated measures to use to then be able to identify people that are likely to get contractures and then intervene for those people. So this is a complex question. If we're looking at prevalence across a population of people, we have this is traumatic brain injury, and Mosley did a very interesting paper, which I think we certainly will come back in terms of our discussion today, but 11% of that population had a contracture at the elbow. That's out of 724 people. Singer, traumatic brain injury, 16% out of a population of 105. Getting to the upper limb, though, it starts to become a little bit more significant. So being able to get your hand up behind your head, 25 out of 50 people could not do that. So that's a significant issue. And in terms of the strokes population, this is an early paper by Andrews and Bohannon. 80% of people in an inpatient service at that time, 20 out of 25 people developed a contracture over a period of a month in their external rotators. I'm now going to talk just very briefly about effective immobilization, and to go back to some of the earlier animal research to understand some of the reasons around this. So what happens to the active and passive properties of muscles? What then happens in terms of stretching in humans? And where do we go to from here? So the animal research is really quite clear. In a whole range of animals, they've used rats, mice, cats, dogs, rabbits, and so on. They all respond in the same way. If you put a muscle in a shortened position, you get a contracture. The contracture happens very quickly. In mice, it happens, these morphological changes begin to happen within 24 hours. So they lose sarcomeres, the muscle atrophies, You get changes in the connective tissue. It becomes quite disorganized and matted and linked across one another rather than having that sort of beautiful wavy, sort of almost, it's quite exquisite. This sort of just lovely little waves that occur in the connective tissue becomes quite disorganized, and you get this increase in stiffness as well. But importantly, if you take animals and put those muscles in a lengthened position, the opposite happens. They grow sarcomeres. The muscle becomes less stiff because you have more sarcomere to connective tissue relationship, and so on. So it seems to be a purely peripheral response to an imposed stretch. And one of the researchers that was involved in this early animal research, Pamela Williams, went on to show that if you have a muscle, this is in mice, if you have that muscle in a contracted position for 23.5 hours, if you stretch that soleus muscle for half an hour a day, that's enough to stop those changes from occurring. You stop the sarcomere loss, you stop the connective tissue reorganizations. You had a look at these under a microscope. So this was a very positive outcome. Wow, perhaps we can prevent contractures from occurring. So in the absence of other evidence, the view at that time, the expert evidence, if you like, expert opinion at the time, was that we can prevent contractures if we stretch prophylactically, because many stroke survivors were seen. And if you look back at some of those early photographs of people with stroke, particularly those that didn't receive the sort of interventions that they're receiving these days, quite often their hands would be profoundly contracted up under their chin, and their arms were quite contracted. So it's commonly seen. And so the aim was to try to prevent those things from occurring. And if we look at the positions of stroke survivors, and even these days, this is a man waiting for his dinner in the dining room. Arm is internally rotated, elbows flexed, forearms pronated, fingers are flexed, and so on. So commonly seen position. Here's somebody looking over their practice sheets before they're going to begin again. So once again, adduction, some elbow flexion, forearm a little bit pronated, fingers flexed. We then went on to have a look at the resting positions of stroke survivors' upper limbs on our stroke unit. So we followed people around from the moment they got out of bed to when they went back to bed. So they were followed up for 12 to 14 hours a day. And every minute of the day, we checked to see the position of their upper limbs. And 78% of the day, they spent with their arms in that adducted, internally rotated, elbow flexed, pronated position. 21% of the day, between 45 and 90, and 1% of the day above 90 degrees. And so the assumption was that, whoa, no wonder people get contractures, because they spend so little time in this position where their arm is actually in a lengthened position. And so we then went on to look at combining upper limb and lower limb stretches. So here somebody's in external rotation, elbow extension, hand is around a large can, and also their foot is in a dorsiflexed position. And they would stay in these positions for half an hour, 45 minutes a day. Here's somebody else on a tilt table on a 15-degree wedge. Their arm is in forward flexion here, but not in that really flexed position, but out in front. They could also practice their protraction while they're in this position. There's a timer there in front of them so they can call out when their time is over. So for me, then I was interested in thinking from my masters to follow up with, well, what do elderly people do with their arms during the day? How often do they get into these positions of external rotation, positions of up to 90 degrees or above 90 degrees? And I evolved a little observation chart that I used. And I followed people around for 12 hours a day. For the first 4 people that I observed, I then looked at differences between the afternoon and the morning and the afternoon, and then randomly allocated my observation time to the morning or the afternoon. And I observed people for a total time of over 100 hours. So I have 100 hours of observations. But after the first observation of 3 or 4 people, what I was going to be seeing was quite obvious very early on. So what I saw was that people spent 90% of the time with their arms above 90 degrees. And the only time that people got their arms up into these sorts of positions is when the environment demanded it. For example, putting their blankets up into the top shelf of a blanket cupboard, or getting the dog food off the top shelf, or reaching over the seat of their car to get their handbag out of the back seat, and so on. So there's these various environmental demands that meant that people got their arms up in these sorts of positions. They spent very little time between 45 and 90 degrees, only 6% of the day. Most of the day they spent with their arms in exactly this same position that we see stroke survivors in, that is adduction, internal rotation and elbow flexion. And also the interesting observation was that people always, just about always, had their arms supported. If they weren't using their arms, then their arms were resting on something. And I suspect that if you look around the room where you're sitting now, you'll find that everybody's arm is supported, and they're probably in this adducted and internal rotated position. External rotation, the same, 1% in external rotation, that is beyond the midline into external rotation, and 99% of the day in internal rotation. There was a weak association between time spent in external rotation and external rotation range of motion, but not clear. So this was fascinating. So if we go back to this graph that I showed you earlier, we've got to be careful of the assumptions we bring to information. When we first saw this graph, the assumption is that this is why people get contractures. But in fact, these stroke survivors were spending 21% of the day in this 45 to 90 degree position, either in forward flexion or abduction, is because they were being stretched, that they were spending time in a forced position with their arms in these positions. Now I'm going to go on to have a look at the interventions for the research related to providing stretches to upper limbs and what the outcomes are. So this first study of Natasha Lannon's, she was trying to prove that wrist extension splints needed to be made in a extended position to actually, because in that position they provided a stretch across the flexor surface of the forearm and would be more efficacious than a resting splint. 63 people were involved in the trial within 8 weeks of their stroke, and they had no active wrist extension. High quality study. So I was talking before about following the rules for a randomized trial. She's followed all the rules that you can follow for a randomized control, except for 2. And those 2 are that she couldn't blind the people after stroke who had the splints because they'd observed that they'd have the splints, and she couldn't blind the therapists to the fact that these people had splints. Even though they weren't wearing them during the day, the potential that the therapists would see the splint lying around somewhere may bias those therapists towards the intervention. So she compared people wearing a functional resting splint, one of these splints that just sort of maintains the hand in that position. And the belief at that time is that it maintained the integrity of the joints around the fingers and the wrist passively, so that then the structures of the hand would be maintained. A wrist extension splint in the maximum the person would tolerate. So in other words, they found where the person could get to and made the splint at that range. And the splints were modified if need be to ensure they maintained that range during the time. The control group received no splints, so their hands were left to dangle whatever position they're in. Splints were worn between 9 and 12 hours a night for 4 weeks, 7 days a week. And the measurement that we've seen before was this one, where they were given a stretch at the beginning. The force that was applied at the beginning was recorded on their initial measurement sheet, and then the blinded assessor that reassessed the people, so they didn't have any idea which arm of the trial they're involved in, they then used the same force across the wrist to see whether in fact there was any change in range of motion. And as we've seen in that force range of motion curve, that if you apply the same force and the tissue had become less stiff or less contracted in terms of getting that range of motion, then we would have seen a change in range of motion. And what did you find? Well, the functional resting splint, the mean difference between the groups was 1.4 degrees, and the confidence interval, 95% confidence interval, was -5 to 8.2. So it crosses 0, and there's really no difference between the groups. But that's sort of understandable because that's what you would have expected. The interesting splint, and the one that was really particularly of interest, was this one, the extension splint. This was completely unexpected. 1.3 degrees difference, -4.9 to 2.4. This is not the outcome that was expected in this study. The outcome that was expected is there would have been a clear difference of this group. They would have all been on the positive side of the scale and that they wouldn't have crossed 0. But disappointingly, once again, no difference between the extension splint and the control group. So research is important, and it's important to follow the rules so that you know that your assumptions don't influence the outcomes. In patients with acute stroke and no active wrist extension, routine splinting for 1 month for 9 hours a day does not reduce wrist contracture. It certainly didn't in this population of 63 stroke survivors. Very disappointing outcome, and not the one that was expected. So what do we do with information that is really hard to digest? Because I can tell you, at the time when those results came out, nobody believed them. It was really hard to actually accept, because our belief system was that stretches in and of themselves will make a difference to range of motion. So we need to find a way to represent this information so we can digest it a little bit more easily. And one way of doing that is to express it graphically. So in this graph, we have stretch makes the range of motion more, and in this case, the stretch makes you worse. 0 is no change between the groups, and we want to have some benefit so we can decide as clinicians, well, what's a worthwhile benefit of wrist extension splint? And we can make that decision that somewhere between 5 and 10 degrees is probably a clinically worthwhile difference. The expense of making the splint and the expense to the patient of wearing the splint, there's a whole range of costs, if you like, in relation to the splint making. So if we put the results in of that study, that's what they look like. So it's very much around 0. So we can now start to build this picture in this graph of all of these outcomes and see what we finish up with as we look at the evidence. Another study done here in Australia, a high quality study, 8 out of 10. Intervention was this one, where people spent their time with their arm in external rotation, elbow extension, and their wrist over a telephone book like this. If their finger flexors were a little bit too tight, then the edge of the telephone book could be moved a little bit so their fingers could rest over the edge. They stayed in this position for 30 minutes a day, 5 days a week for a month. And the control group received no stretch, and both groups received their normal intervention of OT and PT. And what you found was interesting, and this study is perhaps one that's worth thinking about for interventions, particularly for those people you're seeing chronically in the community. And if they can get into this position, perhaps this is a worthwhile thing for them to do if they need to have some ongoing maintenance of range of motion. What you found was that the group didn't lose range of motion in that first month. And then she followed them up 1 week later and then 1 month later. And in this period of follow-up time, they didn't do the stretch. The control group, on the other hand, this is their loss of range, and they continue to lose range over time. At the end of this month period, the intervention control group comparison was that there was a 5-degree mean difference between the groups at 4 weeks, but that wasn't quite significant statistically, minus 0.9 to 11. However, Sally was hoping for a 10-degree difference between the groups, so this is not the outcome that she was hoping for. 4.1 at 5 weeks and 3.5 at 4-week follow-up. So both groups are then starting to lose range at seemingly a similar rate. So the question about this study and this particular intervention, is it clinically significant? But I think perhaps this is worthwhile considering for individual cases if they can get into that position. If we now move on to putting these results in, that's what they look like. So some people had a benefit. Here you can see at the other end of the trial, but some people didn't. And the overall mean effect is just above 0. This is the Anne Mosley trial I talked about earlier, which is a randomized controlled trial, high quality trial, 26 people with traumatic injury, and they all had an elbow flexion contracture. In this study, they received serial casting in terms of the intervention group, and that was for 2 weeks. The other subjects in the control group received their usual 1 hour a day stretch for 4 weeks. And then the primary measure was the passive joint extension range of motion. And once again, a spring balance was applied across the elbow to make sure that the force that was applied was consistent across both groups. They were measured at baseline immediately when the cast came off, and 1 day later, and then 4 weeks later. During this 4-week period, both groups received 1 hour a day stretch, which was the usual practice. So the group that received the serial cast also received a stretch for this 4-week follow-up period. What did she find? Well, really quite exciting results initially. 22 degrees difference between the groups, 13 to 31, quite clear difference that everybody in that group responded very positively to the serial cast. 1 day later, the difference between the groups was 11 degrees, 0 to 21, so still statistically significant, but only just. 4 weeks later, even though they'd been receiving their 1 hour a day stretch, 2 degrees difference between the groups, minus 13 to 17. So now they're back to the mean. So in the absence of muscle activity around the shoulder joint, and that wasn't the question that Anne Mosley was asking about, does serial casting and training on top of that make a difference to range of motion? It was really the question around serial casts. And this is an interesting study because if she hadn't done the follow-up study to show what the outcomes were, then we wouldn't know what the long-term outcomes would be. So serial casting induces transient increases in range of motion, but they're not maintained just with stretch alone. So perhaps training is the important thing. If you're going to use a serial cast, then really try to use that increase in range of motion to then promote the capacity of muscles to work around the joint, and perhaps to bivalve the cast so you maintain the range in that lengthened position when the person isn't doing their training. So if we look immediately afterwards, that's a fantastic result. That's everybody's across on the right-hand side of the graph. Everybody has changed in a positive direction, and it's statistically significant. 1 day later, it's starting to come back to the mean. And then 1 month later, it's back to where they are. But you can still see there's a variability in that population. So some people are still staying positive within this population. So there may be individual cases where in the absence of training, they still maintain that range. So if we now look across other populations, spinal cord injury, which is where this research really began, no difference in lower limb muscle length for gastrocs, hamstrings, Minor difference for ankle dorsiflexion, but that was somebody standing for 12 weeks, 30 minutes a day, 3 times a week with their full body weight over the ankle, and a 4 degrees difference between the groups. So if we start now adding all of the sort of research so far, the overall summary, except for these ones where there is this large difference here, in the serial casting paper, they're all very much around 0. Those first two papers, there was no clear measurement using force. That's in the stroke population. This is traumatic bone injury, spinal cord injury. This is a mixed population of spinal cord injury and stroke and traumatic brain injury. And this was looking at some web space contracture and whether in fact a splint worn overnight for 9 to 12 hours would have been sufficient to improve abduction space for the thumb. And that's the difference between the groups. Quite clearly, no difference. If we put in this clinically significant line of 10 degrees, and that will change obviously depending upon the joint, but overall we can see that the majority of the outcomes are negative, which is not a good message for us in terms of intervention. Other studies have now looked at different interventions, so providing electrical stimulation in that shortened position in subjects with traumatic brain injury post or stroke. They wore a splint for 12 hours a day, and then one group were randomized to receiving electrical stimulation while they were wearing the splint. And they measured once again, their range of motion using 3 Newton meters of torque. And initially there did seem to be a difference, but it still crosses 0. So that's the outcome, but they're heading in the right direction. But 2 weeks later, without the electrical stimulation, the group is coming back to that central point. But it's more complicated because in high spinal cord injury, it's actually a benefit to have a contracture of the thumb for pollicis longus contractures, so that when somebody extends their wrist, their thumb will come across the palm of their hand and give them the ability to pick things up in that space between the thumb and the finger. High quality trial, subjects across C4 to C7, even though it's primarily the C7 group that would benefit from having the ability to extend their wrists. Time since injury, 10 years. Splint was worn nightly for 3 months. So this splint which pulled the thumb across the palm. And so this is an easy group to randomize because you randomize one hand or the other hand to the study. So it means that they both get the same environmental impacts through the day. The results in this trial, it was 0. So we couldn't, in this study, they couldn't actually induce a contracture in that muscle, and quite consistent results between -6 and 6. So if we look at those results, that's what they look like. So this is really becomes more and more curious and difficult to understand when we start looking at this research. But the overall conclusions are using splints, controlled torque, or serial casts, they don't appear to cause lasting changes in range of motion in acute spinal cord injury through TBI or stroke for these joints. And there's an overall summary in the Journal of Physiotherapy in 2017. And just to remind you, the Journal of Physiotherapy is free online, so you can download that paper without any difficulties. How do we interpret these results? Are they well designed and do they minimize bias? The majority of these papers are around 8 out of 10. So they do fit that criteria of being high quality trials. Is it sufficient dosage of intervention? 9 to 12 hours a day in terms of the splinting. It's hard to see that somebody would wear a splint for longer than that. So These are all questions that we need to ask and think about, well, what is it possible for us to do during the day? But the outcomes are still reasonably consistent, that in fact there's no difference between the groups. However, it's primarily in acute populations. And the other thing is that the dosage of rehabilitation or the interventions, the other interventions they received, is not documented. So it's really difficult to ignore this evidence. If you want to look at the Cochrane systematic review of this research, which looks across outpatient stretching, quick stretching, all of those papers, then have a look at the Catalinic review in the Cochrane collaboration. That's free online once again too, so you can chase up the papers up until 2017, and then any research since then, that's where you can then start to look as well to see if there's any changes. There's lots of other questions to ask, so it's not an area where we can now completely say, well, we don't need to think about this anymore, but so far the results are disappointingly negative. So what do we do with information that challenges the way we think? Well, we can burn the messenger, and that seems to be happening somewhat now too, in terms of information that people provide that's evidence-based, scientifically based, that they get rubbished perhaps. And so we need to think very carefully about the quality of the information, and then what the implications does that have for us when we're providing information to the people that we see. There are some glimmers of hope though within this. So here's a very small trial, but one to think about. So this is in a traumatic brain injury population of 10 ankles, so it's not a large population at all. People were randomized to either receive the intervention or not. So the intervention group received serial casts and a multiple range of interventions, including botulinum toxin, motor training, and so on. So they did receive the full packet of information, if you like. So at the completion of casting, their range of motion at the ankle was 26 degrees into dorsiflexion, with a consistent response of 20 to 31. At week 2, this is without the serial cast, but now with training and ongoing intervention, still 26 degrees between the groups. And at week 8, so this is 6 weeks after that, once again, still statistically significant. So now we have possibility that providing serial casts and training at the same time, and lower limb is perhaps different from upper limb in that you can demand that people load their leg, that they can begin to practice standing on the foot, and they can start to step forwards and do all those things to maintain their range of motion, sitting to standing, so they're moving their knee forwards over their foot and so on. That this program then enabled them to maintain their range of motion. So it's only one study. It needs to be replicated, and we need to start thinking about measuring their outcomes in terms of walking and sitting to standing and so on. But in this population of people, I'm sure they were very happy that they received this intervention. So here's a case study, once again by the same physios, a young man who has profound contractures and really has no capacity to move. With 18 months of serial casting and then maintaining the range in this newly acquired range, and then motor training to get their legs to be able to push and begin to load their leg. 18 months later, able to stand. So this is a chance for this young boy to begin to be able to move, to be able to stand with assistance, and then perhaps begin to be able to learn how to walk. So this is a good case study, but the message for me is that this needs, once again, this very high levels of intervention. Secondly, you need to measure. And thirdly, it actually requires muscle activity around the joint in addition to those stretching interventions. So to stretch or not to stretch? Contracture is a problem for some people, and as we saw in the other research, 4% of that the population with spasticity had these problems of pain, can't open their hands, made a big difference to their functional capacities. Are there alternatives to stretching? Or perhaps ongoing and early high intensity training to get people to start to use their arms again, protraction, elbow flexion extension, electrical stimulation around the joints so that they begin to see that their wrists can work, uh, try to sustain that range of motion, but it probably needs to be really intensive. We don't know how intensive for that to make a difference. So how much practice? We don't know. So that's the advocating for measuring dosage. So when you're working with people, you really do measure the dosage of practice that they're doing. How long do people need to be followed up for? Well, it's probably for the rest of their lives. How do we start to provide that intervention? And perhaps the new funding around NDIS will then start to offer that opportunities for people to have drop-in classes. This experiment with telehealth and rehab perhaps gives us an example of how we can continue to follow up people when they're at home and try to maintain their function and their interventions that they're doing. Perhaps this is a stretch that people could, if they don't mind doing it, that this is one that they could do. It's the one positioning program that has shown to have some influence over the loss of range of motion. But we have a conundrum that people can do astonishing things and we don't quite know why. Is it because they have a difference in their connective tissue, or is it a difference in terms of their tolerance to stretch? And Lisa Harvey has looked at this issue around tolerance to stretch in people that don't have brain damage. Just stretching hamstrings for a month, just half an hour a day, she found that in fact people in that group, even though the force that was applied to the hamstrings at the end of the stretching period, the range of motion was exactly the same. The population that had the intervention leg, either the left or the right, they allowed that leg to be stretched much further. In other words, their brains, the tissue hadn't changed its extensibility, but their brains had changed in terms of perception of threat, of stretching that muscle. So they allowed the leg to move a statistically significant greater range just because they'd been going to that stretching period. That's interesting because maybe what we're doing is changing people's brains in relationship to this perceived threat of stretch. And certainly for me, after my period of time in ICU, I like to stretch, but one of the problems for me is trying to stretch again after that period was exquisitely painful. And it's taken me about 6-9 months after that period to begin to do the sorts of stretches I was doing before. So maybe there's an issue around my brain changing, but not so much my tissue. So that's the summary of this information so far. So what I might do now is throw it open to the chat room for any questions.